tobacco use, chronic inflammation, whether the patient has undergone neonatal circumcision, which is protective, whether there's been pre-malignant lesions like chronic balanitis, lichen sclerosis, poor hygiene, and associated HIV and AIDS. And you'll characterize the lesion by site, the size, number, induration, whether it is associated with ulceration or not. Then you will acquire a histological diagnosis by biopsy depending on the size. Large ulcerated lesion, you will take an incisional punch biopsy. If it's a very small thing, you will undergo, the patient will undergo excisional biopsy, and you will assess for HPV status. Then then you will check for inguinal nodes. So each one of them, first primary, will go through the pre-malignant lesions. Then how do you assess the T stage? Then you will go for inguinal nodal status. Then you will how to combine both and treat. And what is the adjuvant treatment? That is what is penile cancer all about. So what are the pre-malignant lesions associated? Here you have to know the histological varieties, SCC and its variants, HPV associated and non-HPV associated. SCC and variants are Barty, verrucous, papillary, sarcomatoid, and basiloid. All good varieties are HPV associated, and they will be basiloid warty or warty basiloid. Rest everything you can put under non-HPV. So it can be non-SCC, verrucous, papillary, sarcomatoid, whereas basiloid, warty basiloid, they come under HPV related. Coming to pre-malignant lesions, so red lesions, erythroplasia of Curette. It's an squamous carcinoma in situ of the glands and the prepuce. If it is associated with association with the shaft, it's Bowen's disease. Then if it is intraepithelial adeno, it is Paget's. So squamous, if it is glands or prepuce, it is erythroplasia of Curette. If it is shaft, it is Bowen's. If it is not squamous, it's adeno, then it is Paget's. Then Buschke's-Lowenstein tumor, it's also called giant condylomata acuminata or verrucous carcinoma. It's a very localized disease without predilection for nodal or distant metastasis, associated with low risk HPV 6 and 11. It is very superficial, does not invade the adjacent tissue. The same Buschke's-Lowenstein tumor, that's also low risk HPV associated. They are large lesions. They also have a larger growth without predisposition to nodal or distant metastasis. So by microscopy, they are round, broad. They have red apex cells, which is surrounded by chronic inflammation. So for them, excisional biopsy is sufficient with follow-up. Then the other lesions are BXOs, balanitis xerosis obliterans, I think.
Balanitis erotica obliterans.
So balanitis erotica obliterans and keratitis, balanitis, and other is cutaneous horn. So the three things will be carcinoma in situ, whether it is squamous cell. In squamous cell, whether it is in the shaft or in the prepuce or the glands. If it is adeno, Paget's. Then going ahead with non-HPV related, that is cutaneous horn, keratitis, balanitis, and BXO. HPV related are all big giant associated with low risk types like 6 and 11, that is condylomata acuminata, bovenoid papillosis, and Kaposi sarcoma. Then your treatment is mainly depending on the depth of invasion and whether it is associated with LVI. So there are multimodality, meaning you can use multiple, not multimodal, multiple options if it is very superficial, that is T1A. For that, let us know the staging. So T1 is divided into T1, T2, T3, T4. T4 is largely invading everything adjacent. So it can be scrotum, prostate, pelvic bone, everything. Now T1 is very superficial. It reaches beyond the basement membrane into the lamina propria, but does not include anything like a corporal body. Nothing is involved. So, excuse me. So it is again divided in by grade and LVI into subdivision A and B. No LVI, grade 1 is A. So T1A is beyond the basement membrane, like subepithelial tissue and fascia, everything can be involved, but the corporal bodies are not involved. And it is LVI negative. Coming to B, it is high grade, grade 2, grade 3, with LVI is T1B. Now, depending on the corporal body's involvement, it is T2 and T3. If it is spongiosa, then it is 2. If it is cavernosa, it is 3. Plus or minus urethral involvement. The urethral involvement will not change your T stage. So your T stage entirely depends on the depth of invasion, involvement of the corporal bodies or adjacent organs, and you will include LVI as and grade 1, grade 2. This is important because your very superficially lying T1A lesions can be managed with any superficial modality like local excision, most microscopic surgery with RT, or you can give 5-fluorouracil topical application, lasers, all of it. Going 1B and below, even 1B, you might use every other modality except most microscopic surgery. But once it includes the corporal bodies, then you have to do excisions, wide local excision, partial penectomies, total depending on the remnant stump. So this is the use of T staging. When we go to groin, or we'll finish off N, then we can finish here. So N3 is the worst. What are the things included in N3? Fixed nodes. If it is clinically fixed, then it will be any extranodal invasion positive. Pelvic nodes, all of it will come in N3. Then N1 and N2 are differentiated by number and laterality. So 3 nodes, three or more nodes, bilateral involvement is N2. Anything below this is N1. So the worst of all is N3, which is fixed ENE pelvic. N2 is more than or equal to 3, bilateral. 2 or less than 2 is N1. So then coming to management, let's see how
इसका
we
पैथोलॉजिकल
manage.
अलग होता है ना?
These are all pathological involvement only, I think. No?
पैथोलॉजिकल अलग होता है. नीचे आओ, नीचे आओ.
No, it is all P only.
आई हैव सीन अभी कहीं. ठीक है, वो रास्ते में आ जाएगा, कोई बात नहीं. इसका पैथोलॉजिकल और क्लिनिकल थोड़ा डिफरेंट रहता है. हाँ, इसमें होगा.
This is nodes are almost the same only.
N1 unilateral, N2
in T, I don't think there's a difference.
Huh?
Extra. C is C, mobile unilateral inguinal node. N2 is mobile more than or equal to 2 unilateral and bilateral. Okay, N3 is fixed. So
pelvic lymphadenopathy भी इसमें ही आता है.
हाँ, fixed pelvic N3. N1 is mobile unilateral. Everything else will become N2. So it will be more than or equal to 2, and bilateral will be N2.
Come to pathological.
In pathological staging also it is the same, but it's only 3, 2 and 3. Otherwise same only everything.
2 unilateral और ENE आ गया ना. ENE तो automatically fixed हो गया, तो ENE हो गया.
So all ENEs are in N3 only. Here also there is no difference.
Okay, okay. वो फिर शायद टेस्टिस या किसी और का होगा.
Okay. So coming to T stage management, what are the local therapies? So if it is even in situ, you will resort to all topical. You'll be as minimalistic as possible because this is organ preserving, which will improve quality of life. So a topical IFU imiquimod twice daily for 28 days. You'll use laser or glans resurfacing surgery. You will do less mutilating surgeries. Then coming to TA, which is not breached the basement membrane, which is intraepithelial. So here you can do as small as circumcision, you can do wide local excision, you can use lasers and glans resurfacing, same as this one. So in T1A, now there is breach of membrane into the lamina. Here you will resort to excisions, wide local excision, and there is role for RT. Very superficial like IS and TA, you will not be able to put your catheters along and give or mold also. RT can be used in very good grade T1, T2, grade 1, grade 2, T1A, where surgery or RT is preferred. Here, depending on the location, you will do wide local excision or partial resections. If it is less than 4 centimeter, then you can give RT. So interstitial implants are preferred to do. Then beyond T2 and beyond, don't even think of anything of this sort. You have to do partial penectomy or total penectomy, but RT can be given if there is a size less than 4 centimeter, but you avoid to write beyond T2. So you can write only partial penectomy, total penectomy with perineal urethrostomies. Then coming to very advanced disease, wherever you see bulky nodes, fixed nodes, bilateral, inguinal with pelvic involvement, then adjacent structures T4 where the surgery is very mutilating, increased post-op complication, then you will resort to give neoadjuvant chemo. You will see the responder, then you will decide whether to go ahead with surgery or you will consolidate with some RTS palliative intent. Now, so organ preservation, that is TIS, TA, very good grade T1A, grade 1, grade 2. Yes, you can do all these organ preservation as minimal as lasers to as maximal as glands resurfacing. You can use RT for less than 4 centimeter lesion. When do you resort to amputation? So these are the 4 indications. Tumor more than, so I remember it as 3, 4 CU, 3 grade 3 lesion, 4 by size more than 4 centimeter. C is corporal cavernosal involvement. It is almost come onto the dorsal side of the penis, and urethral involvement. In all of these, you cannot do anything less than penile amputation. So you cannot use organ preserving modalities for these. So when you write about organ preservation, you will write about all these options. Now coming to groin. Groin, what you have to remember is only one thing. Here, staging of the groin is always invasive, irrespective of your clinical or imaging, meaning your palpation or imaging, no matter how much ever it gives you negative, you will have to do a invasive staging to confirm the occult metastasis. So how invasive? It goes from minimal to maximal. The bare minimum that you have to do is dynamics SLNB. Next is superficial template dissection. Then go to deep, or you do modified complete, or you do standard inguinal dissection. So this is how you have to do. But you have to remember in N0, you have to do one or the other form of invasive staging. Who are all those people who can avoid addressing, your inguinal, just like melanoma, less than 1 T1B. So because there is no LVI in T1As, you can avoid to, invasively stage the inguinal region. So it is TIS, TA, T1A, grade 1. In whom
दैट वो
only
ग्रेड थ्री
minimally
सी यू
advanced.
तो तुम ऑलरेडी बता ही चुकी हो ना, ग्रेड 3 T4 वो तुम ऑलरेडी बता ही चुकी हो.
That you have to address the node wherever you think the occult metastasis is more. So in these low risk people, you can resort to surveillance. You can call the patient regularly. You can do ultrasound and you can monitor. Another thing from the old guidelines is there is no policy of giving
एंटीबायोटिक.
antibiotics and waiting for it to regress, because they found that it's not going to make any difference. If it is palpable, yes, you have to do some form of invasive staging. That's all. In spite of giving antibiotics, if it regresses, if it doesn't, it does not change your decision of diagnosis. Now, fine.
वॉइस गया फिर से. नो इंटरनेट मेरा.
So these are the options that you have. Dynamic SLNB, modified template. In modified, I will first see what are the templates. Just one diagram I have here. Yeah. So the yellow color is laterally is the sartorius. The medial one is the adductor longus. So these are the two muscles that you have to remember. The two vessels will be femoral artery and femoral vein. Now, let us go from farther to the newer templates. The original one that gave ilioinguinal block dissection. That was a template which had 20 and 15 as numbers. So the landmarks are ASIS, you drop line at 20 centimeter, pubic tubercle, you drop a 15 centimeter downward line. Then two horizontal lines, you will connect these 2 points, and the first 2 points will be 1 centimeter above the inguinal region. So this is a very broad template where you will go beyond the muscle and the morbidity was very high. Then you will condense the template. Then you will restrict your templates to the muscle. If it is sartorius to the lateral, adductor longus to the medial, and if you constrain yourself superior to the inguinal ligament and where this two muscle converge, that is your standard template, and it is called Dassler's template. DASLER, Dassler's template. Then
डेस्लर्स वाला ही तो पहले था. ड्रेसलर्स वाला जो फर्स्ट यू टोल्ड दैट वाज डेस्लर्स.
ilioinguinal that got modified to Dassler, that got modified to Catalona.
क्योंकि ड्रेसलर्स क्वाड्रेंगल नाम से वो फेमस है, जो तुमने बाउंड्रीज बताई ना, उन बाउंड्रीज का नाम ही ड्रेसलर्स क्वाड्रेंगल है.
Okay, I'll recheck then. This is what I got it, but I'll recheck. Okay. Then you will condense the template into your lateral boundary will not go beyond the vessel. So your femoral artery will be your lateral boundary, and that is Catalona's template, where this concept came just like our clocks classification in breast axilla. Here you will have to draw a plus, which is oriented around the saphenous entry to the femoral vein. Then you will get 4 quadrants, and central one is 5th. I don't have pen to show you. Just imagine. So you fix a clock over this. The central is over where the saphenous drains in the femoral vein, and that will be your 5th. Starting from anti-clockwise, it is 1, 2, 3, 4, 5. It is clockwise only. 1 will be upper medial. 1 lower will be 2. Outer will be 3, 4 will be above, and 5 will be at the joining. So most of the veins are found at 1. Nodes are found at 1. So that is upper inner. So they found that this Catalona template was associated with less morbidity because you're not going into wider field. You're not even ligating the saphenous vein here. Pretty much you're preserving most of it here, and the post-op complications were less. And yield also was more, and your staging was accurate, and it had therapeutic benefit. When do you resort to standard versus modified? When you're doing staging, it is Catalona. Whenever you're trying to give a therapeutic benefit, go laterally till the muscle, go deep, superficial and deep, and remove everything. If it is fixed node, too many nodes, very bulky disease, you've done it post neoadjuvant, then you use your older ilioinguinal template. Otherwise, they say between the muscle is more than enough. So after knowing the template, we'll see how we'll manage it. Now, first you did dynamic SLNB, where there are a combination of 2 techniques. Day prior or 6 hours prior, you gave a radiocolloid, you mapped your lymphatics and the nodal uptake. Then you gave methylene blue, just like your axilla, dual technique, where then you will map your hot and blue nodes. Here you will send them, you will do serial sectioning, IHC, everything, and it can be done as staged procedure also. Otherwise, if you pick up a positive node, then you will go ahead doing a standard ILND. If it is negative, then you can resort to surveillance. So, ilioinguinal block dissection. According to European guidelines, they have a larger margins, meaning it should be more extensive to use a original template, otherwise modified is enough. So the thing is, it should be more than or equal to 2 nodes, extracapsular extension and pelvic nodes, then you use a larger template. But you can write standard template for all of it. Now coming, otherwise, now you think your center does not have expertise for this, then you will do Catalona template, only superficial nodes, send it for frozen section. If it is involved, take out the deeper nodes also. Otherwise, for staging, superficial Catalona is more than enough. Next, coming to N plus. In N plus,
superficial catalona. सुपरफिशियल इंग्वाइनल लिम्फ नोड में पूरा वो जो तुम टेम्पलेट बता रही थी ना, वो पूरा टेम्पलेट कवर होता है.
Superficial and deep depends on whether you go deep to the fascia or you stay
क्योंकि
above the fascia.
इंडिया में जो एक कैटेलोना है ना, ये आई थिंक एक्सेप्टेबल नहीं है.
See, for staging, everybody says do superficial catalona. See, catalona dazzlers or your complete is only lateral borders. Superficial and deep depends on how above the fascia and how below you. So for staging, your superficial modified is enough. Only if it says negative, then go ahead. If that was not the case, this idea of invasive staging would not have come if were doing deep for everyone.
No, not deep. I am not talking about deep. I am talking about that modified जो तुमने बोला था ना, superficial हम लोग करते हैं, deep नहीं करते हैं. बट जो कैटेलोना मॉडिफिकेशन है कि सिर्फ मीडियल वाला निकालते हैं, लेटरल वाला नहीं निकालते हैं, वो वाला कॉन्सेप्ट हम लोग रूटीनली यूज नहीं करते हैं, इसलिए पूछ रही हूँ. अवनीत, लास्ट टाइम हमने कुछ डिस्कस किया था ना इसमें.
No. Even for N0, you'll go lateral to the femoral artery.
हाँ, यही मैं बोल रही थी.
Okay. But this is what when we go to NCC also, I think it's the same thing that they've written.
एक मिनट देख लेते, रुक जाओ, तुमको पढ़ाओ, तुम्हारा स्क्रीन शेयरिंग चला गया.
आ गया क्या? ढूंढने तक वेट करूं क्या? यू सर्चिंग समथिंग?
नहीं, तुम कराओ ना, तुम कंटिन्यू रखो. यू कंटिन्यू.
Okay. In N plus nodes, what is addition is if there is clinically palpable node, radiologically also seen, then do FNAC. Confirm whether it is a node positive. So here, what are all the other prerequisites? If it is ipsilateral, node positive, very mobile, less than 4 centimeter, according to ma'am's diagram, she says you have to do FNAC or you will do excision and then observation and positive ILD. So according to NCCN, you will have to doubly confirm your negative nodes. So you did FNAC, it came negative. Do your excision. If it comes negative, then you can resort to observe. But otherwise, you will have to do minimal invasive staging like dynamic SLNB or modified inguinal dissection. So this is what this has to say. What are the higher risks? So if it is bilateral N plus, then you can consider to do FNS is what ma'am is given. What NCCN says is anything is that you just do FNAC, negative do excision, then again if it is negative go into invasive staging. So when we go through NCCN we will see it there again. Then when do you resort to give NACT? Fixed, bulky nodes, bilateral, even pelvic are involved. When we say N3 disease, then you give induction, see for the response, do surgery. If it is progressive, then you convert your intent of treatment to palliative, give chemo or RT or hospice care. So the same thing she has told the chance that more number of nodes are involved, the chances of pelvic node involvement is more. So when do you address pelvic nodes? So more than or equal to 2 positive inguinal nodes. That is N1 also. Clinically N1, N3 and bulky more than 3 centimeter or bilateral inguinal involvement all of this you have to address the pelvic nodes. So where and all you have role of RT. In curative setting, very superficial lesion less than 4 centimeter without urethral involvement to the primary, you can give RT. Second, a progressive non-responding patients, palliative RT. There is no role in prophylaxis of high risk N0. Without staging, you cannot give RT to the inguinal region. And in adjuvant setting also, they say there is no role of RT. Then there is a role, you can write RT, EBRT, brachy for local control only. Side effects are stenosis, necrosis, fistula, stricture, all of it. So what is the neoadjuvant chemotherapy? It is TIP, cisplatin, taxane, and ifosfamide. Paclitaxel, yeah, ifosfamide and paclitaxel, I think. Cisplatin, paclitaxel, and ifosfamide. So this is what inguinal dissection, superficial and deep system. Then these are the templates. Then strategies. When we go, okay, SLNB, I anyway told you how it is done. Then let us go into NCCN only, what it has to say. So the complications here will be skin necrosis, giveaway, then lymphocele, seromas, then infection, blowout, bleeding, re-exploration, lower limb edema, all that, venous edema, all that you can write. Then, okay, let us follow the templates here. So you worked up a penile suspicious lesion. You did an excision biopsy. It came as intraepithelial neoplasm. It is not breached in basement membrane into the lamina. So your primary treatment is more than enough. If the node is negative, if it is involved N plus, then you will follow the N plus template. If it is more than or equal to T1, now there is lamina propria breach. If it is grade 1 without LVI, then you can resort to only local treatment and observe. If it is more than 1B, then addressing your inguinal by invasive staging is mandatory. T2 and greater, you will do some form of amputations, partial, total, or chemo RT or RT for poor risk category patients. Now coming to nodes, there is no palpable node, and you will look at the primary. It is very low risk, then you will do surveillance. If this non-palpable inguinal node is associated with intermediate or high-risk patient, that is T1B and beyond, then you will do additional imaging for ruling out metastasis. Then you will do some form of invasive staging. So it can be bilateral dynamic sentinel node biopsy or bilateral inguinal lymph node dissection. Then you will do surveillance depending on P category. Now you had an N plus node. You even ruled out metastasis. Now you will categorize them as unilateral, less than 4 centimeter, mobile. That means they are non-bulky nodes. They have low risk of primary. Then you will have to do FNAC. If it is negative, confirm it by excision biopsy. Then again, if it is negative, okay, then you will do surveillance. So you have to double confirm your FNAC. In case it came positive, then you will do your inguinal dissections. So it is bilateral ILND. Then again, if this lesion is high risk lesion, it was a T3, T4, then you consider to give neoadjuvant TIP, follow risk. Again, you see for how they respond and then go ahead. If it is bulky node, fixed node, bilateral node, pelvic nodes, then they say there is a role for neoadjuvant therapy by TIP response assessment. Then you will go for ILND, and if these characteristics were there, you will include even pelvic node dissection. So pelvic lymph node dissection. This is about the primary and follow-up. So organ sparing, same thing. They've given topical application laser. It can be a CO2 NETDR laser, KTP. Then wide local excision glanectomy, most microscopic. All of this come under penile organ preserving approaches. Amputations will be partial or total penectomy, and your surgical management of inguinal node. Standard or modified or SLNB is indicated in N0 if high risk features of nodal metastasis is present. That is more than T1B, lymph, and more than 50% of poorly differentiated. Then
इसमें टेम्पलेट्स नहीं दिए हैं क्या?
templates here they have not given, but this is from my slides I had prepared, and this is in our hospital we follow Catalonazole for staging, and for completion we will go till Sartorius. That's all.
Okay.
So yeah, what we were saying, indications for pelvic node dissection. Was it? It should be considered for more than or equal to 2 positive inguinal nodes on ipsilateral ILND or in presence of ENE, that is fixed nodes. Bilateral PLND should be considered either at the time or following as a staged procedure with more than or equal to 4 positive inguinal nodes. So in radiotherapy, for early disease, we saw the cutoff as 4 centimeter. Then following penectomy, post surgical, if no gross disease. So this is for indications for this one will be T3, T4 and N+. This is unresectable. For adjuvant, okay, chemo RT adjuvant is bulky nodes. That is P N2 N3, you have to do some form of extra treatment like pelvic node dissection. Then you have to give adjuvant CTRT. All that is there. For your negative margins, when do you resort to give adjuvant therapy? Surveillance.
Your screen stop sharing.
Yeah. Yes. Where is it? Yeah. Everywhere it is. Yeah. This is neoadjuvant. And adjuvant. Okay, excision. But after a complete surgery, margin negative, nothing. Only if, depending on your P staging only, your adjuvant is given. Otherwise, pretty much it is surveillance. Only in your margin positivity, then only you will give. Otherwise, it is N2, N3 pelvic nodes were there, then you will give adjuvant therapy. This is the preferred regimen tip. Paclitaxel, ifosfamide, cisplatin. This is also used in neoadjuvant or adjuvant setting. So we saw that bulky nodes, fixed nodes, in all of them you'll, and T4 larger, this one you will see whether it can be downsized and then operated. So adjuvant EBRT or chemo RT can be considered with high risk features, that is pelvic node, extranodal extension, bilateral inguinal nodes and more than 4 centimeter nodes. So if bilateral inguinal nodes are also there, then you have to do pelvic. So same thing for pelvic nodal dissection also and adjuvant. So these are all high risk features. So you will have to consider doing giving some form of adjuvant therapy. So this is for relapse, recurrence. Actually, more than T1B only. When there is N plus, you will have to do metastatic workup also. If it is more than T1B, local and metastatic workup you can include. Okay, in WHO, yeah, pathological classification. Here, this is actually new, I think, where precursor high-grade lesions, that is squamous intraepithelial neoplasm, high-grade HPV associated, that is basiloid warty, pagetoid, clear cell, and differentiated intraepithelial neoplasm, which is HPV independent. Then in invasive, again you will divide them into HPV associated, HPV independent. HPV associated are warty, basiloid, clear cell, lymphoepithelioma like, and mixed. Independent are squamous, verrucous, papillary, sarcomatoid, and mixed. So in HPV independent, you can remember mixed in sarcomatoid, squamous anyway, you will write. The other things are squamous, not otherwise specified, and other epithelial like mixture of adenosquamous, mucoepidermoid, paget, extramammary. Pathological prognostic factors of penile is aggressive histologies are basiloid, clear, and sarcomatoid. Best is verrucous. Then grade 1 to 3 are the. Otherwise, this is the same thing. T1B, T1, T4, yeah. So N1 will make it stage 3. So whenever you get clinically positive nodes, it is up stage to 3. So the very good variety only sticks to stage 1A. That is stage 1. That is T1A. Then 2 can be divided depending on the T size into A or B. N plus will become stage 3. That is again N1 or N2. Stage 4 is all bad. So your T4, N3, M1, all of it will come in stage 4. And that is why when there is T4, you will resort to neoadjuvant and see if it really works. That's all. This template I'll confirm. But what we will do is Catalona followed by ILND template.
ठीक है। मैंने अभी वही पढ़ रही थी तो मैं देखा कि करते हैं, तुम जो बोल रही हो ना वो भी करते हैं।
We follow this one. And for therapeutic, they go as wide as that 20 centimeter, 15 centimeter old template or standard template?
ड्रेसलर क्वाड्रेंगल इटसेल्फ जो तुम वो बता रही हो ना कि सार्टोरियस और वो उसी में ही आता है। दैट इज ड्रेसलर क्वाड्रेंगल ओनली जो तुमने बताया ना 20 और 15। The sartorius and that abductor magnus
along this
that is only distal quadrangle na.
The lateral extent you tell me you
देखो मैं बता रही हूँ तुमको बाउंड्रीज ऑफ स्टैंडर्ड फुल टेम्पलेट ILND इसको डेस्लर्स क्वाड्रिलेटरल एरिया बोलते हैं। Superiorly inguinal ligament, inferiorly fossa ovalis, laterally medial border of sartorius muscle, and medially lateral edge of adductor longus muscle.
Correct. This is Drassless quadrangle only. That 20 and 15 centimeter is the old template.
वो नाम ही ड्रेसलेस क्वाड्रेंगल है, यही मैं तुमको बोल रही हूँ। उसका नाम ही वो जो ओल्ड टेम्पलेट है वो यही है, बट उसमें प्रॉब्लम क्या थी कि वो सब कुछ निकाल देते थे, सेफिनस वेन भी निकाल देते थे एंड दे वेर रिमूविंग सेफिनस वेन अभी हम बचा लेते हैं। ठीक है, जो
then we don't do sartorius transposition, that we don't do. Then we don't like it, that saphenous vein. Then we stick to most of the retrieval where most commonly the occult metastasis like.
तो मॉडिफाइड टेम्पलेट में जो तुमने बोला वो ही मॉडिफाइड टेम्पलेट में सेफिनस वेन बचा लेते हैं। ठीक है, और proposed by
Sartorius
shorter skin incision, inguinal dislodging, excluding the area lateral to femoral artery, caudal to fossa ovalis नहीं जानना है, the preservation of saphenous vein, and
no
elimination the need to transpose sartorius muscle
Correct.
while providing adequate therapeutic effect.
Correct.
ठीक है, तो ये मॉडिफाइड टेम्पलेट है.
Template. Yeah.
ठीक है.
Hmm.
और इसके अलावा इसने कोई टेम्पलेट दिया ही नहीं है एनसीसीएन
That
ने.
so all diagnostic you just write dynamic SLNB and modified template. When you do formal dissection, just write standard ILNB.
सुपरफिशियल इंग्वाइनल लिम्फोडेनेक्टमी होता है कि सिर्फ फोसा ओवलिस के ऊपर का, फेशिया के ऊपर का जितना भी लिम्फ नोड है वो हमको निकालना है, उसको हम सुपरफिशियल इंग्वाइनल लिम्फ नोड डिसेक्शन बोलते हैं.
Superficial to the fascia.
हाँ, सुपरफिशियल टू फेशिया, दैट इज फेशिया ओवलिस और फेशिया लाटा जो रहता है उसके ऊपर का जो लिम्फ नोड्स निकालते हैं उसको सुपरफिशियल इंग्वाइनल बोलते हैं. वो इसने इसमें दिया ही नहीं है.
First, when you're writing staging, you can be minimal template. That's all. In all your N plus, better to write standard ILND. That's all.
ओके, हो गया पेनिस. पेनिस फिनिश.
हाँ, only this there was.
Okay.
Groin N plus, N0, primary. That's it.
अवनीत तो स्पीकर बोल ही नहीं कुछ.
She must be tired.
चल दिव्यांग गया, मिलते हैं कल. बाय.
ठीक है 4:30.